It's a pleasure for me to be here among many colleagues and nurse colleagues. I've been active in clinical pediatrics for over 25 years. I think up to maybe slightly more than 10 years ago, I was still dealing with issues like, and I remember we were together in some meetings with Trevor Duke, which I should thank for inviting me, and Peter as well, that I recognize now, but I just had some mail exchange with him. I was dealing with issues like how much fluids should we give to children with bacterial meningitis, or should we use steroids? And then from these kind of issues I gradually moved to other kind of issues, kind of policy issues, how to get intervention through, etc. I'm not seeing my presentation here, so maybe should I get... I have to, yeah, all right, that'll do it, just to know. I thought it was automatic. Yeah, all right. Thank you. Perfect. Thank you. So I've been given the task to discuss with you some of these issues regarding implementation of child survival interventions and policies. And I will do it as a sort of discussion. Of course, it's going to be a little bit of unilateral discussion where I talk, you listen. But anyway, within me, at least, it is still a discussion because I don't pretend to have the final word, and I'm still looking for what is the real way to get through these very difficult issues. I will divide my presentation in two parts. In the first part, I will discuss with you what are the underlying determinants of child health outcomes. And of course, this will lead us to consider what are the policy implications of this. And then in the second part, I will get more into the real operational, implementational issues with some examples taken from different countries. So underlying determinants, you see these two children, they are not just, by themselves, they are within an environment, in this case a kind of a toxic environment. This is a microenvironment, there is a macro environment around them. And of course, we have to take this into account, even when we are taking care of parts of these children, maybe the brain or the abdomen or something else. I'm sure that Trevor Duke, in his initial keynote speech, has talked about these appalling figures about the causes of death in under 5 children. These deaths are still above 10 million every year. As you can see, most of these causes are quite basic, I would say. Pneumonia, diarrhea, measles. And among causes of neonatal deaths, there are still issues like tetanus, diarrhea, infections. But what is still impressive is the fact that over half of these deaths are attributable to malnutrition. That is to say, if that all children in the world were well nourished, we would have less than half of these deaths every year. This is a bit of work of my group about the underlying determinants of neonatal health. I don't want you to get through the whole slide, but just consider that neonatal outcome is not just about birth weight or delivery care. It's about the income of that family, the tradition of that community, the age of the mother, the practices, traditional practices of that community, and of course about the healthcare. So there's a very complex pathway that we have to consider when we finally are facing the outcomes of these pathways. Social class is a crucial determinant. You see in these countries that the poorest 20% of the population has an under 5 mortality rate which is threefold or twofold that of the better off part, better off 20% of the population. So it is very clear, and I think I'm saying just the obvious, that social class is a powerful determinant of child health outcomes everywhere. And a corollary of this is that if we would be able to extend to all children in the world the kind of health outcomes that are typical of the 20% better off part of the population, we would, just by doing this, avoid almost half of the child deaths. Another powerful determinant of child health outcomes is women's literacy. You can see here 4 curves. They regard maternal mortality, child mortality, neonatal and postneonatal mortality. And in all cases, it's quite remarkable the effect of women literacy on these mortality rates. Why poor children are at higher risk of death? There is a proverb from Niger that says that poverty is the grandmother of ill health. And I think it is a way to understand why poverty is mediated by other factors. What are these other factors? Exposure to risk factors, for example, to unsafe water, lack of sanitation, poor housing, crowding, and many others. And then we have a susceptibility issue, which is the baby which is just born premature or with a low birth weight due to intrauterine growth retardation. And sometimes these two combine. The baby is born weak and low weight, and then he is or she is exposed to unsafe water, crowding, bad nutrition, and so on. Or it may be that the baby is born healthy, but then after a while, due to environmental condition, he or she gets sick, and he gets weaker, and nutrition status is worsened, and the immunity starts to get weaker and weaker, and so he gets sick, and severely sick, and so on. And then finally, we have the issue of access and quality of health care, which is just not the only issue in this matter of child health and child survival globally. Well, this is a picture that shows how inequity is still extremely strong. You see that there are countries where the poorest 20% doesn't have access to the basic essential of child care, like immunizations or antibiotics for pneumonia. And you can see that a few countries perform a little bit better just because their middle class is performing better. This is a picture that should tell us what kind of interventions and policies are necessary in order to change the situation. Inequities are growing, or at least they are not improving. This slide is about delivery attendance, which is crucial for neonatal survival and well-being. And you see that the enormous discrepancy between the richest and the poorest has not changed much over the last 10 years. And this is a slide from the De La Monica group from Unicef. To start to understand what is behind this situation, this is a bit of piece of work by my friend Cesar Victora, child epidemiologist from Pelotas, Brazil. He has shown quite brilliantly that one of the causes of this situation is the fact that the poor people have a much slower and lower uptake of whatever new technology you introduce. You introduce oral radiation, you introduce antibiotics, new immunizations, and so on. And then, of course, the richest pick this up much quicker, these interventions, and with the result that the immediate result of introducing new intervention, which is not saying that we shouldn't do it, is to increase inequity. But this is important for us to understand what else we have to do if we want to change this situation. Let's consider this slide again. In Brazil, we have up to 1/3 of the population which is not totally able to access essential intervention like antenatal care visits, birth in a health facility, or skilled attendance at birth. That happens in a country relatively developed like Brazil. Let's look at the lower line regarding Ethiopia. More than 4/5 of the population is totally excluded from this basic health intervention. So this is not just about delivery of care. It's just about the fact that these women are not able to even understand the importance of this kind of health interventions. They are not informed about this. They are not empowered to ask for this. Sometimes they are not allowed to do this. So this is sometimes something that goes really upstream, and we should consider this when we consider the policies that we have to develop and implement. And one other piece of information that might surprise you, most benefits of the programs still go to the better off, in spite of all the effort to reach out for the poor. Irrespective of the fact you are in Africa, East Europe or Africa, or Eastern Europe or Asia, are the better off those who benefit more from health interventions and also social intervention. The benefit incidence, what is it? It's the percentage of the benefits of one program going to the poorest 20%. Now let's look to what happens to many health programs. Due to the fact of the access issues and to the demand issues, most of these benefits go to the people that are not those most in need, with a few exceptions. So let's come and see now the situation from another point of view, the point of view of what really happened in the countries. And this is a work commissioned by the World Bank, and it shows quite clearly that the child mortality and the child health indicators improved much more in those countries that invested in redistributional macroeconomic policies, invested in basic education and schooling, invested in food security, water and sanitation, and of course in universal access to health care. There are tremendous differences, and this is not just about health care, it's about something which is much broader than this. And these are exactly the same factors that allowed children in Europe. We have very precise data from the UK, but the situation is just the same in other countries, that allowed children in Europe to get much better health, even before that health interventions, such as those that we have available today, were made available. Now, let's look at this pyramid. This is not an indigenous TP, and it might not be a perfect drawing. I'm not very good at drawing, particularly when my eyeglasses are far away from me. But I would like to show this top of the pyramid, which represents you, in effect, critical care people. And I think you are aware of the fact that if you are good in your work, you achieve immediate results. You save lives. And I think that you are also aware of the fact that by doing this, you may have limited impact at the population level, because numbers are relatively small. You save 10 lives, 100, 200 in a year, so on. So I would like to show that if we talk about health interventions, usually what we get is short-term results with an impact which may be significant or very important depending on the area and depending on the country. But if you want to achieve long-term result and a sustained impact, you have also to invest in those factors that are linked with the basic determinants of health and disease, included the demand for health, which is essentially about women's education, empowerment of communities, and their capability to understand their rights. And it's important to understand, and I think there is a little bit of link with the previous presentation in what I'm saying here, although we are talking now at global population level and not at the individual level. But when we talk about this intervention, it's not just about supplying things, antibiotics, health interventions. It is also about the demand. It's also about the population, the role that populations play. And I think governments have a crucial role in eliciting this demand and supporting this demand. Otherwise, there is no perfect delivery strategy that can compensate for this lack of demand. This is just a slide which is made by economists, and it's showing that the earliest the investment in health and education, the best returns you get. And I think most of the governments are not aware of this. Although I am also quite aware of the fact that they may realize this, but unfortunately the political interest and lobbying usually is in favor of the needs of the better off, the urban population, the adult, usually male population, and this is probably the major obstacle that we have to face. So let's come to the second part of my presentation. I would like to discuss with you something maybe more concrete and more nearer to your reality, which is what are really the obstacles that impede that many effective interventions reach their target. This is again a slide from the group that is trying to follow up with the Countdown Initiative to 2015, which is an initiative linked to the MDGs, and trying to help countries to achieve this MDG 4, which is about reducing child mortality by 2/3 by 2015. As you probably know, we are far away from reaching these objectives in the majority of the countries. So this slide is about 8 of the basic essential interventions: immunization against measles, diphtheria, pertussis, tetanus, vitamin A, skill and attendance at birth, anti-malarial treatment, oral rehydration, care seeking for pneumonia, insecticide-treated bed nets. And these columns represent countries that are on track or out of track or completely out of track. And you may not be able to distinguish from there, but the blue column are those countries that are on track, which is the minority of countries. Most of the countries are completely out of track, so they are not able to ensure the coverage of those very basic and low-cost interventions. So let's try to understand why this happens, and I will now not use anymore my words and opinion, but refer to a working group that we had a year ago when we were discussing in Vientiane, in Laos Republic, the launching of a new child survival strategy, which was a WHO-Unicef joint initiative. So we had this working group with health professionals and policymakers from all these countries that you see here, high mortality countries: Cambodia, Laos, Vietnam, Papua New Guinea, Philippines, with the adjunction of China. And we will use for this analysis of obstacles and implementation issues the WHO framework, which was used for the World Health Report in 2001, which identifies 4 main issues: the financing issues, the human resources issues, the strategy issues, delivery strategy issues, and the stewardship and management issue. And see what these people said, what these people identified as major obstacles. Let's take the financing issue. Lack of integration of child survival intervention in current health plans, resulting in insufficient funding. As I said before, adult health is still in the view of most policymakers not an issue or not a priority issue. So there is no sufficient funding. Free access to key child survival intervention at point of delivery is not available for most of the poorest. And I must say this is not improving, because health reforms are increasingly putting obstacles and fees to pay and other kind of obstacle to access for the poorest. Health expenditure ceilings at both national and local level. You can go beyond 2 or 3 or 4 or 5% of the GDP, depending on the countries. The poorest areas get the less money from the central government. I've shown before how this is a widespread reality. So what they were proposing to overcome these obstacles? Of course, child survival plans have to be integrated within the national health system plans and reform. Otherwise, you keep preaching, and the mainstream goes exactly in the other direction. Expand the coverage of health insurance, which should be, in principle, universal. Health is right. And at least free access to key child survival interventions. Increased proportion of funding for child survival integrated intervention at the central and local level. So that is something that has to be discussed and achieved, and of course this is essentially a political issue. And compensation mechanism in resource allocation at central and local level. Some countries have adopted a percentage proportion of total funding that should go to the rural areas or to primary health care, for example. Human resources. I'm sure that Trevor's mentioned this as a key critical area. I'm not talking now about the global shortage of human resources. Let's see what happens in many countries. The deployment of key staff in poor areas is extremely difficult. The recruitment and training is sufficient for key health professionals, for example, midwives. And there is poor motivation and lack of incentives for these health professionals to reach out for the poorest communities. So we should try to look for incentives, monetary and not necessarily all monetary, for health professionals to work in poorest areas. Try to imagine allowances for cost of outreach activities in order to compensate for the extra cost of these activities, and set up national and local training plans for specific health professionals. Delivery strategies. Lack of focus on outreach delivery strategies. Lack of integrated delivery channels. Logistical problems in outreach. And so once more you have to plan explicitly for this kind of outreach activities as a part of the usual business. You have to imagine that midwives should deliver integrated intervention like pre- and postnatal care, breastfeeding, EPI, and others, and try to avoid vertical, separated programs. And you can think about, particularly in some countries where transport is an issue, distances are great, about waiting homes for delivery care also as an opportunity for integrated care and information communication to the population. And then there is the management stewardship issue. We lack good health managers, particularly in the periphery. There is poor managerial capacity, no incentives to integration, lack of supervision, and so on. And so, without getting in all these details, I think that a crucial issue is to capacity building for intermediate health managers, those that can really make the difference once that sufficient funding is ensured. And there are many other issues that were indicated by this group of people: welfare system insufficient. Of course, insurance schemes need to be broadened and include all part of the population, lack of transport, and so on, starting from the education of health professionals and education of the population as a whole. And I will skip a couple of slides to remain within the allowed time. And just to make you an example which I had to deal with in Yemen, this picture actually is from Mozambique, but in Yemen there is a big issue about delivery care, particularly in rural areas. So Unicef started to think about a program to train midwives. Many other problems had to be faced. For example, midwives had to be deployed in rural areas. There were not houses for them. There was an issue of transport. At the end, the program didn't end up with much success because it was evident that many sectors should have contributed to the success of this program. The salary of civil servants, even the recruitment of midwives due to the low education enrollment of girls in this particular country. So that's an example of how cross-sectional action is needed in order to obtain results. It's not just about the quality of delivery care. And I will end with a few recommendations, if you want, or a few lines that you should consider when trying to improve child health outcomes in your country. I think national child and adolescent health plans should be thought of, based on a situation analysis to identify system bottlenecks, combining health intervention with health system policies and cross-sector policies, combining short and long-term action in national plans, improving integration and continuum of care, and ensuring accountability and monitoring. This is a piece from the European Child Health Strategy, which is not just about Western Europe, as you may imagine. It's about Central Asia, the Caucasus, and where there are still many countries with high mortality levels, up to 60, 70, 80 per thousand. 3 levels of actions were identified for each specific objective. For example, if you want to improve maternal and neonatal health, you have to improve legislation to support working women during pregnancy. You have to improve registration of birth. You have a health system action, which is about provision and access to care. It's about training of health professionals. And then you have the health intervention level, where you have to improve the specific quality and technical contents of each specific medical intervention. So a sensible strategy should include actions with different temporal perspectives. Short term, improve, for example, case management. Medium term, strengthen community health through community health workers. These are just examples. And long term, improve nutrition at population level in a sustained way through a food security national plan, which is something that, for example, the Republic of Senegal has recently engaged in. And I think without this kind of combined policy, it's very difficult to achieve sustained reduction in child mortality. I will skip a couple of slides again and come to a couple of last thoughts about the coordination among agency and government sector. This is point 2, which is still much needed. Recently, we have done we have been able to achieve a little bit of more coordination through the global partnership on maternal child, newborn child and adolescent health. And now the agencies are trying to work around one plan, one monitoring system, and trying to coordinate their work in countries, which is a very much welcome initiative. Then, as I said, you have to strengthen the health system components, which is not just about staff, but it's about management, supplies, etc. Integrating intervention and ensuring the continuum of care along the various levels of care. And then, finally, once again, develop and enable policies to promote demand and access among the poor. And this is my final slide, which again puts the ATP, which is the primary pyramid of interventions. And I think that probably linking with the conclusion of the previous speaker about the nurses, but this is not just about pediatricians, it's about all health professionals and nurses as well. We do have a role below the tip of the pyramid, outside the ward where we work. We should be able to promote integration and continuum of care within our own intervention perspective. But we should also ask, as a community of professionals, for stronger health system. And within this health system, we should ask for an advocate for more effort to improve maternal and child health through effective and equitable health interventions. And finally, I think we should also advocate for equitable and early investment in human capital. Education and health are the basis of a country's development. In early 1900, Japan arrived to invest over 50% of its global available budget in education because they had to face the challenge of getting in the global arena from a previous isolation. So that's an example of how a country can really invest in development by investing in early stages of life in human capital. This is something that has to be get through the mind of our politicians. And I think as a pediatrician, as child health professional, we have enrolled in that. We have a role in advocating for this. And I think that if we reach this, there will be somebody who will thank us for our critical care. Thank you.